The ischemia trial. Ischemia stands for lack of blood flow. That's what that word means. It's a medical term. There was a trial that just came out. It hasn't been published yet. It was presented at the American Heart Association meeting last week. And yet again, it was supposed to be the definitive trial. And many guys are saying, yes, it's the definitive trial. John Mandrola, many of you may know him. He's a cardiologist in Louisville who, like me, basically pushes more for lifestyle management of heart attack and stroke risk. I started to cover his work, but we were rushed to get everything ready. So I'm just going to cover the New England Journal view of this space. His perspective, like mine, is this should change everything, although it probably won't. And you'll see why in just a few minutes. Basically, this is supposed to be the definitive study showing that, look, they compared CABG, CABG bypass graft, or stents with lifestyle and medical management. They did it with 5,200 adults. These adults had ischemia. In other words, it was documented that they had they were not getting a proper blood flow to their heart. And here's what they found. At 4 years, incidence of the primary endpoint, a composite of cardiovascular death, myocardial infarction, in other words, heart attack, resuscitated cardiac arrest, hospitalization for unstable angina or heart failure. You put all those together, there was no difference between the people that had the bypass graft or the people that had lifestyle and medication management. So they looked at another endpoint in the study where they said, look, we're just looking at cardiovascular death or heart attack, MI. As you see here, that's where I'm just reading that right off of the summary from the New England Journal. It also did not differ significantly. Now, here's where I will say that I do tend to get a lot of, maybe not so much hater comments, but comments like, well, I don't know, I had a stent and it improved my angina. We'll talk about that later. There was an ORBITA trial a couple of years ago that where they did a complete sham operation. This was in England. They probably wouldn't do that in the US, but they took people, they put them into the OR, and some people, they actually did the operation, the stent, other people they didn't. And you take those out and follow them, and there was no difference in angina for those patients either. So again, I know I'll get a lot of folks that say, oh, wait a minute, but my stent worked. I'm not arguing with you. I'm just telling you what the trials are showing. Dr. Harlan Krumholtz, editor-in-chief of the New England Journal, the Journal Watch Cardiology, said, the ischemia trial is a lot to digest, and the results haven't yet been published in a peer-reviewed journal. Yet, what seems clear is that patients with stable ischemic disease, in other words, loss of blood flow to the heart, are safe with medical therapy, which is consistent with many other studies. And when he says that, he's again referring to the COURAGE trial, the ORBITA trial, and other trials which have shown that lifestyle and medication management are have the same outcomes as the invasive procedures. Now, he went on to say a side question is whether stress myocardial perfusion studies are providing much value for these patients. And to translate that, stress myocardial infusion studies means a stress test. So again, I hate to keep hammering this point, but the research is out there hammering that point over and over again. So before we get much more depth, I'll cover some things in terms of what we're offering, what's available, summary resources. Just make sure you're, again, a reminder and that you're aware of the membership page. On the membership page, you can access all of our courses. We've got a new course out there now, the plaque evaluation course. It's how to evaluate plaque and how not to. And most people these days are evaluating plaque the wrong way. That is, they're using stress tests. There are better ways. We've got a whole course on how to do that. If you go into the membership page, you can see free parts of all the courses. You can see what events are coming up. And you can get some updates on the upcoming book. You get free infographics. Again, the previews of the books. You also get clarification and registration access to the webinars, the CIMT events, and the bootcamp events. How do you get to the membership page? Well, you go to our website, and we've got a new section right here, membership login. That's all you have to do. Even if you're not a member yet, you click that button, and then you create a free membership right here. Once you do that, it will let you into the membership page. So speaking of events, the Louisville event is over. Well, it's sort of over. We had a great event. We had a lot of people. It was, we had more people than I've usually seen at these types of events. We usually get like a couple of dozen. This was 3 dozen folks. Also, there was a lot more emotion at this event. There were people that shared very openly regarding their struggles and their activities in terms of preventing heart attack and stroke for not only themselves, but for their families, their coworkers. And we got into a lot of detail on how to do that and how to engage others in this activity. The CIMT events, David Mines had his in Anaheim. We had, I think, about 3 dozen people there. I'm going through and making the rounds right now on talking with people that have had a positive CIMT, just to help them understand what that means. David's got another couple of CIMT events coming up soon. I think one the weekend after Valentine's Day. I believe that one's in San Antonio. Clyde, I know you're listening. I know we don't have that information up. Please ask one of the guys to put that on a slide so I can make folks aware of when the next 2 CIMT events are coming up. I think there's one in, there's one in San Antonio, and I think there's one in Pittsburgh coming up soon. We're having another bootcamp event on February 28th in Orlando. We just set the time and date today. It's a 1-day event. I know a lot of people want to try to get into one of these, but they struggle to invest 2 full days. So we're going to try a 1-day event and see how that works. Again, we've had very good responses so far. The exact location, we're not sure yet. That's to be announced, and we're working hard on continuing to improve the pricing for this. Couple of things. Now, we've had a much higher price point because we've put everything together, an evaluation with me, an evaluation with Janice, the labs, the CIMT, 2 days of the boot camp type of event, the room, meals, etc. So what we're trying to do now is break that down so you get a better handle and better understanding on how much these actually cost. And actually you can do some picking and choosing. We're also working hard on actually taking some significant risk on costs to try to help folks access this activity. The webinar series has been going well. As you know, or some of you know, not everybody, just a reminder, the webinar actually includes a couple of labs in addition to some webinar discussion of the lab results. The labs that it includes are some labs that are very difficult to obtain now, the inflammation panel, the OGTT, oral glucose tolerance test, and the insulin response to the OGTT. So you get you dial in with Michelle, set up for that, get those. She gives you a voucher to get those labs with the lab orders for those labs. You go to the local lab, get those done. And then join the webinar and we talk about the lab results. So again, we've had a lot of response to that, a lot of continued interest. The next set of webinars will start, I believe it's January, I believe it's the 4th Tuesday in January. So back to the ischemia trial. I've already covered the basics on that, but let me just cover a couple of other things. So what does the ischemia trial mean? It takes us back to something that we've covered before. Why would you want to do a stent? And in addition, maybe why would you want to do a bypass graft? Well, you clearly want to, there are times when you'd want to do a stent for a heart attack, and it does work. Unfortunately, about 10% of stents that are actually being done are being done for heart attack treatment. The majority of stents being done are being done for prevention. And as we saw in the COURAGE trial and here with the ischemia trial, stents don't prevent heart attacks. We also saw that with the ischemia trial that bypasses don't prevent heart attacks. Now, why is that going backwards? That is, now here's the place where a lot of comments come in. Again, I mentioned haters before about this topic. A lot of folks will respond and say, I had angina, it's cleared up. I'm not going to argue with you on that. I would just refer you back to the ORBITA trial that I described earlier, where they actually took people in for a stent. Some people, they did the stent. Others, they just took them into the OR, put them to sleep, brought them back out, didn't do the stent. And the two groups, the study group had the same amount of angina as the group that had stents. So, and one of the most common, maybe the most common reason for putting in a stent and for looking at a bypass graft is, quote, blockage. So in other words, you've got blockage in that artery. So if you're an interventional cardiologist or a thoracic surgeon and your whole life is about cleaning up arteries, then if you're a hammer, everything tends to look like a nail. A lot of folks, again, are saying that the new ischemia trials are going to change the way medicine is practiced. You know, I talk to my friends and they don't think so. You know, again, I don't mean to be too critical of medicine. Clyde? I don't mean to be too critical of medicine and the medical complex, but here's the bottom line. If you look at hospitals, financially, they tend to be driven, especially in the cardiology sections, they tend to be driven by the number of procedures that they do, meaning bypass graft, stress tests, and especially, well, stents and bypass grafts. If you start looking at the ischemia trial and start assuming that that ischemia trial is going to result in the cardiology departments of this country and heart hospitals of this country cutting their bypass grafts and their stents by 90%, I don't think so. So thank you for your interest. Let's go in and see if we've got some comments. Okay, Kazbach live, yes. Cheryl Walter, howdy. Thurston Howell III, we can see. Good morning, Terry. Gianluigi from Milan, Italy. Good to meet you, Gianluigi. Kazbach, simple comment. Answer is money. Yep, Kazbach. Wonder if I can get my money back for my cabbage, my bypass graft. Very cogent statement, Kaz. And I greatly appreciate you sharing that. I know that you go through a bypass graft and that is a big, big deal. It's a life-changing event. And now we're starting to see maybe that was not what it was hyped up to be. Felix Gonzalez, hi from Spain. I'm Felix. Good to meet you, Felix. Thank you for dialing in. 1957 Cato. Hello, Dr. Brewer. Bob Weiss, hello. From the Georgia Mountains, and Thurston Howell III. that sounds familiar. You didn't actually end up getting shipwrecked with a fellow named Bob Denver playing the role of Gilligan, did you? Johnny Midnight, I'm looking forward to the say when I can do my own blood work at home. Johnny, you can do a lot of it at home already. If you can call Michelle, we can get you set up with, and actually others have done it just direct to the lab. It's oh, having a senior moment. The Meridian Valley Labs offers a Kraft insulin profile. Meridian Valley Labs Kraft insulin profile. So you can get that on your own. You can't get, I'm not familiar with any place where you can get the inflammation studies on your own. But again, call Michelle, she can help you get that through us. And Thurston Howell III said, yep, you've been on a shipwreck with Bob Denver. Okay, so I can remember Bob Denver and Gilligan's Island from what, 30 years ago, 40, 50 years ago, but I can't remember Meridian Valley Lab. That's just the way my brain works. Love to see some comments. Otherwise, we will wrap it up soon today, quickly today. Clyde Castaneda. Oh, thank you, Clyde. Okay, so Clyde's printed out the events for you. The CIMT events are February 28th in Orlando, February 15th in San Antonio, April 4th in Detroit, May 2nd in Memphis. And Clyde, we also have one in April, what is it? April 17th, I believe, in what, central western Ohio, near Dayton. That's with our good friend Mark Bentley, and he's got a couple of local dental societies which have joined together, and they're sponsoring a CIMT and full educational event for what we do, as well as a for some people who want to choose to buy up and get a complete exam, we can do that as well. So, Kazbach, thyroid T3 supplement treatments, low body temperature, or do we do those? We do those, if that's your question. Johnny Midnight, if you have a high LPPL, I think what you're saying is LPPLA2, what strategies can you take to lower it? First of all, I have a couple of patients who continue to have an elevated LPPLA2. However, their MPO, their microalbumin creatinine ratio, their HS, high sensitivity C-reactive protein, all remain normal. And when we first started, they did have inflammation, more of a complete panel of inflammation. So if you do some research, you'll find that there are some folks that tend to run a little bit of an elevation of plaque 2. If yours is reflecting inflammation, though, again, we all know what the activities are. First, find out the root cause. And for at least 80% of us, I would say probably more, it has to do with insulin resistance, prediabetes, metabolic syndrome. Even if we're not heavy, even if we're thin like me and a bunch of other folks, we talk about the obesity epidemic driving diabetes. Yes, it does help drive diabetes. However, one thing that's stronger than obesity in terms of driving diabetes is age. I'm 62, and the vast majority, well, the majority of us over age 60 have significant insulin resistance problems. It's part of what happens as we get older. So, but back to your point, I think it's Kaz that made that point. Back to your point, that's why we look at a panel, not just one inflammation marker. Terry Wyatt, Dr. Brewer, are you aware of stevia and any insulin response? I am, not only am I not aware of seeing an insulin response with stevia, I tell you, I think there's significant evidence that it doesn't really stimulate significant insulin. For example, if you had folks that were fasting, if you had folks that were taking stevia, you would tend to get hypoglycemic episodes from that. I haven't seen any significant research in that space, but again, I'm very skeptical that stevia and even the other non-nutritive sweeteners create significant insulin response. If you look at look it up on the web, you'll see that all of them do. You'll also see that all of them cause obesity. You'll also see that all of them cause, or statements that all of them cause insulin resistance. At the end of the day, you got to start looking at the problem of confounding. And I haven't seen a good study yet that didn't have what we call confounding. What that means is, if you're insulin resistant, if you're diabetic, if you're obese and trying to lose weight, what are you going to do in terms of drinks? You're very likely to start using stevia and the other non-nutritive sweeteners. But even with, I do believe this, that stevia is probably significantly safer than the other non-nutritive sweeteners. I personally, when I use a non-nutritive sweetener, I clearly prefer stevia. I don't run and hide from the others. I am getting, by the way, less and less addicted to the non-nutritive sweeteners. That's always been an issue for me. But if you look at the hard science, the literature out there, again, I think that a lot of the quote dangers associated with these non-nutritive sweeteners are overstated. I think there's some fairly good evidence which indicates that at least other than stevia, the other ones might actually change your gut biome a little bit, not a huge amount. But again, so I personally, what am I doing? I continue to try to get off of my sweet taste addiction, my non-nutritive sweetener addiction. I will occasionally use non-nutritive sweeteners other than stevia, but I'm still using stevia probably, 3-4 times a week. Johnny Midnight, all of my tests are normal, just high LP little a. Okay, different question, very different question. Yes, as you might imagine, Johnny, I have, given what I do for a living, I have a ton of people that have elevated LP little a. And it depends on which kind of study you're looking at. I won't even get into the actual numbers, because again, they'll vary based on the lab and the study that you're using. But you could say between 25 and 33% of people actually have some significant elevation of LP little a. There's a gene pool, French-Canadian gene pool, which tends, that has very high LP little a's. I've got a lot of patients from that group, a lot of patients that have what we would call world-class LP little a. Now, here's the first thing to remember about them. It's sort of like FH. Despite all of the anger and frustration and fear surrounding LP little a alone and FH, familial hypercholesterolemia alone, I tend to not see a lot of events for people that have these issues until something else comes up. So you may remember the video where Half a Sue joined us. Her brother called her Half a Sue because she'd lost 100 and she'd lost half of her weight, 130 pounds. She had familial hypercholesterolemia. We've had folks like Joe Riley with LP little a. And again, the major concern is to manage those other risk factors. Now, I haven't mentioned one thing about LP little a. It's really clear that for most people with LP little a problems, niacin helps. So clearly, that's my primary go-to recommendation. Number one, manage all the other risk factors. Number two, do a trial of niacin. Tony Saccone, can a right bundle branch block? I think you went right bundle branch block, which is a tongue twister, be corrected. I'm not familiar with ever seeing that having been corrected, Tony. Gianluigi Petazzi, afraid of the test and drinking 75 grams of glucose because it says my connection's struggling. Sorry if you're hearing some garbling. 75 grams of glucose because I am in keto since a long time. What reaction of my body can I expect if I do the OGTT? Your body's used to that, Joan Luigi. Believe it or not, I'm sure that for many years prior to you going keto, your body was going back and forth between fuel sources. That's what our body is made to do. It's made to burn up glucose primarily, and then when there's not enough glucose to burn, then it goes to fat sources. When it goes to fat sources, you're left with ketone bodies, which makes you ketotic or have keto. That's the goal for people that are in a keto, on a keto diet. They decrease their carbs, not only their sugars, but usually for most of us, an even bigger source of carbs, which would be grains. You give those up and focus on mostly fat and oil sources for calories, but also some protein sources. Again, your body's done that more times than probably either one of us can count. It's used to it. Okay, so Clyde wanted me to remind you that we've made some price changes to the metformin prescription program. It's making it a lot more affordable. If you would like to know more about that, call 859-721-1414. That's 859-721-1414. I see John Panazzo on. John, how are you doing? I appreciate you joining us. Dr. Brewer, I read somewhere that niacin supplementation, 1, 2, 3 grams per day, depletes methyl donors. Should one address this perhaps by methyl supplementation? Thank you very much. Trimethylglycine, TMG. If you see, well, let me just finish that comment. Thank you very much, John, for reminding me. And yes, I do that. If you go to my my video on my morning coffee or my morning smoothie, I talk about where I'm taking TMG, trimethylglycine. That's basically the way that I do methyl supplementation. Chris Masterjohn has a great video where he goes into detail on describing the biochemistry on it and how to supplement for methyl donors. I would also remind those of us that may remember, I have a methylation problem, as do 40% of us. We have methylation problems. Now, if you listen to folks like Z-Dog, he'll tell you that makes no difference at all. I beg to differ. I've shown videos where I've actually gone into the science. Actually having methylation, the guys that are on the side, the pro-methylation problem folks would say it impacts mental health and energy. Others would, like myself, would say whether it does that or not, methylation, people with methylation problems clearly they start showing eye damage earlier in their retina from pre-diabetes, things like that that are very critical to the vast majority of us. So another way to supplement methyl donors, or to supplement methyl, John, is things like, you find them on Amazon, Thorne Methyl Guard. They're methylated B vitamins. I have recently gotten access to one that has been up to now limited only to neurologists and ophthalmologists. I'll be offering it soon. I think over the next week or so, we'll be coming out with a thing. It's called Restore Me. It's got the methyl donors that it provides the methyl donors that you need. It also provides a few other things. Johnny Midnight, I've been doing keto for 4 years and had no issues during the OGTT. I aced the test, by the way. Well, thank you, Johnny, for sharing that. That means that your pancreas is in good shape. Your liver and muscle cells are not pushing back and being resistant to insulin. Terry Wyatt, thanks for the stevia answer. Looking forward to discussing this topic on the next webinar as it relates to my OGTT results. Thank you very much, Terry. As I've mentioned a couple of times, I've been trying to decrease the time to try to get this to about half an hour or less. I see that we're coming up on half an hour now. I greatly appreciate the participation and the interest, and we'll go ahead and sign out. Thank you.